so I'm going to hit my record button so I don't forget. So first, my name is Lisa Gray. I'll get into further introductions in just a moment, but I want to welcome all of you who are on the call that I don't know yet. I am one of the nurses that is working with the EIIC. I wear a couple different hats, and I'll get into those, but if I haven't met you, thank you so much for joining us on our Trauma Domain Steering Committee call today, the very first one, the inaugural Steering Committee call. So we're excited that you could be here. We look like we're going to be, we have an hour and a half set for our time. We might get finished a little bit sooner, but we at least have an hour and a half to start us off. So I'm going to start with an acknowledgement and disclaimer that we start all of our EIIC meetings with. The EMS for Children Innovation and Improvement Center is supported by Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award totaling $3 million with 0% financed with non-governmental sources. The content presented here is that of the authors and does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. So our agenda today, we're going to get started with welcome and introduction. Since this is our first steering committee, we'll dedicate a little bit of time for introductions. Just many of us know one another from different work together, but some of us are new. So take a little time to do that. Dr. Kate Remick is going to give us a background on the EMS for Children program, specifically the EIIC, the Innovation and Improvement Center, for a history and background for maybe those of you who aren't really sure what the EMSC is or what the EMSC does. Next, we'll get into Dr. Dingeldine will give us some purpose and goals of the Trauma Domain Steering Committee, what we're trying to accomplish. Dr. Jensen will then kick us off with really leading an open discussion and priorities for quality improvement. What are we trying to accomplish over the next 4 years via this steering committee? And lastly, we have a survey introduction for you all. We have a very brief 4-question survey that will go out to you following this meeting. So Dr. Jensen and Dr. Dingeldine will both introduce that and kind of what we're thinking around that survey and what we hope to accomplish with it. So I'm going to start with introductions. So I am one of the EIIC Trauma Domain leads. I've been fortunate to work with several of you and many other organizations in my prior role as a trauma program manager for a level 2 community adult and pediatric trauma center. I have transitioned in July of this past year. I now work for the EIIC, the Innovation and Improvement Center. I work with the trauma and hospital domains. I also have a little bit of a role in a telehealth collaborative that we've recently kicked off. So wear a few different hats, learning a ton, but trauma is my background and expertise. I was a bedside nurse in pediatric critical care and trauma, and then became a trauma program manager for 15 or so years. So that's a little bit about myself. I'll turn it over to Dr. Dingeldine for him to introduce himself.
Hi, everyone. Thanks again for joining us today. We really appreciate it. I'm Mike Dingeldine. I'm a pediatric surgeon in Cleveland at Rainbow Babies and Children's Hospital. I'm also my administrative role as the trauma director here. I think along with Erin, kind of recently, last summer towards fall, joined as part of the EIIC grant, and we're put kind of in charge of the trauma domain. And really, this is a brand new project, and we're really looking forward to getting ideas from this group. It's a fantastic group, so we appreciate all of you being here.
I'm Erin Jensen. I do pediatric surgery, trauma, and critical care at UCSF, specifically at Benioff, Oakland. Most of my research and academic interest is in quality improvement and in developing new methodologies for pediatric trauma. I'm very involved with the ACSCOT as well as the Pediatric TQIP program. And I think this is a great project. It's really going to allow us to unify a number of stakeholders, and I think that's shown by who's on the call today, to really set forth quality improvement priorities for how to improve care for kids nationally, particularly outside of trauma centers. I think we've gotten really good at taking care of improving our quality within trauma centers, but all of the critical access hospitals and community hospitals that send kids to my center, we really don't have a lot of reach. into those centers. But this, partnership with the EIIC and the Emsc and the Peds Readiness, all of these collaboratives, which Kate will tell you the whole alphabet soup about, this is a great opportunity for all of us to come together and really improve the care for kids. So, on behalf of Lisa and Mike and myself, we're all exceedingly thankful that you're willing to help us out with this project. And I think this project has the potential to have a huge impact on kids. So hopefully we'll give you guys a better idea of what the heck we're planning to do with this group today.
All right, gonna move on to our partners in project management. Within the EMSC, EIIC space, we are fortunate to have organizational partners with ENA, ACS, and ACEP. So Kathy, I'll start with you at the top if you'd like to introduce yourself.
Sure. Hi, everyone. I'm Kathy Olson. I'm the Director for Quality and Safety at the Emergency Nurses Association. I have oversight of activities, projects, and programs to promote evidence-based quality emergency nursing practice projects. I've been an emergency nurse for over 30 years. I've been with ENA for about 7.5 years. I am involved in a number of domains through the EIIC and other projects. So I serve as the liaison from ENA to these efforts. And let's see what else. My passion has always been trauma. So I have to mention that, of course, because it's very relevant. I was a trauma coordinator in my career for 10 years in a level 2 trauma center. So I appreciate all the background here and experience, and I'm very happy to be a part of the steering committee. Thank you.
Thank you, Bhavin.
Hi, I'm Bhavin Patel. I'm the Program Manager of Research at the American College of Surgeons Trauma Quality Programs. I've been with the college for just over 3 years now. Along with the just research focus initiatives, I do have some involvement with the Trauma Quality Program's pediatric initiatives. And I'm also joined on the call today by Melanie Neal. Melanie, if you want to do a brief intro, if you'd like.
Sure. So I'm the Senior Manager for Trauma Quality Programs at the college, and that includes TQIP and our verification program, all of our efforts around PIPs, as well as trauma systems. And I'm excited to be involved with this group because we're always looking for ways to ensure that our programs are taking into account the needs of pediatric surgeons and pediatric patients. So far it's been, I've learned a lot, and I think that it will be a good partnership for us, for sure.
Terrific. Thank you, Melanie. Sam?
Hi, everyone. I'm Sam. I'm with the American College of Emergency Physicians. My background, I'm an internationally trained EM physician. I've been with ACEP now going on 3 years. I'm also the staff liaison for the Pediatric EM Committee. So thank you for having me.
Terrific. Before I introduce our leadership for the EIIC, I'm asking that each of you introduce yourself. I'm going to kind of just go down my participant chat box, and it looks like Terry is next. Terry, would you like to introduce yourself?
Did you say Terry? I'm sorry.
I did.
Okay. So my name's Terry Ellsburn, and the job I get paid for, I guess, is I'm the Pediatric Trauma Program Manager at the Level 1 Pediatric Trauma Center at the Mayo Clinic, position I've held since 2008, I guess. I also have various activities I'm involved with, trauma related. I'm on the Pediatric Steering Committee of the Society of Trauma Nurses. I do site visits for the American College of Surgeons as the nurse reviewer. And I guess the reason I'm on this call today is that I'm the current president of the Pediatric Trauma Society.
Terrific. Thank you very much, Terry. Diane Pilkey, would you like to go next, please?
Sure. Hi, everybody. My name is Diane Pilkey. I'm the Senior Nurse Consultant at the Health Resources Services Administration with the division that the EMS for Children program sits in. I'm a former ED nurse as well, and was participating in the trauma domain from the last grant cycle. This is definitely going to be a different domain. I'm excited to participate.
Thank you. Next, we have Dwayne Spencer. Dwayne, are you on?
I am. Thank you. Good afternoon, everybody. I currently serve as the State Partnership EMS for Children Grant Manager for Pennsylvania. I've been there for a year right now. And prior to that, I was an educator for a Level 1 Pediatric Trauma Center in Philadelphia, and quite a few years in critical care out of hospital on the ground, and as a flight program clinical participant, as well as a hospital administrator overseeing a critical care program. I look forward to working with everybody.
Welcome, Dwayne. Thank you for joining us. Next, I have Dr. Fallon.
Hi, everybody. I, like Diane, was part of the trauma domain for the last EIIC. I have a pretty long history of taking care of a patient, being active in trauma organizations, and I'm the current co-pen representative from the Committee on Trauma. I also am the National EMS Advisory Council, where I represent the trauma domain. I'm glad to be here. So I think I'm acting in an advisory capacity for this grant.
And you're one of our subject matter experts on this committee. So thank you so much for joining us.
I think when they asked me to participate in this project, one of the criteria for me saying yes was that I would have access to Mary Fallon to share. Happy to have you.
All right. Dr. Taylor, I think you're next on my list.
Awesome. My name is Taryn Taylor. Clinically, I work as a pediatric emergency medicine physician at Emory Children's Hospital of Atlanta. And we are a Level 1 trauma center here. And I am in this role serving as the ACEP representative, where I serve with my ACEP hat as the chair of the pediatric section.
Perfect. It's great to meet you, Dr. Taylor. Thank you for joining us.
Thank you.
And last but certainly not least, Dr. Kate Remick is one of our EIIC leaders. She's the co-principal investigator on our grant. So I'll let her introduce herself.
Yeah, good afternoon, everyone. I think I know most of you. To the people who don't, nice to meet you virtually, and thanks for having me in this meeting. Dr. Macias would be here, but he's on vacation this week, so apologies that he's not here. We have a robust team with Dr. Corey Chumbatazi, who's at Baylor, as well as Dr. Mark Auerbach at Yale, and Dr. Mosa Dinajad, who collaboratively really head up our knowledge management efforts within the EIIC. I am the executive lead with this grant, was part of the leadership team in the last 4-year cycle of the EIIC, and I've been working on EMSC related efforts, I guess, for about a decade now, as many of you are aware of, and we're just excited to be launching so many of these future efforts within the trauma landscape. So thanks so much for being here.
Thank you, Dr. Remick. And I think you'll see on your screen Dr. Auerbach and Dr. Sadinajad, excuse me. Also, I think you mentioned them, didn't you? Thank you. Mm-hmm. All right. We have quite a few other folks. It looks like you couldn't join us today. You have received a directory of each of our steering committee members. I will say that as we talk today and you learn more about our future goals and our future plans, and maybe you have the opportunity to take a look at the directory, I'd like us to also think about who we're maybe missing. We wanted to start out with a group that wasn't too big, making sure we were multidisciplined and included key stakeholders and expertise. Yet at the same time, it's reasonable that we've not included somebody. So I think our steering committee may grow. Specifically, I know we've been in conversations with East and hope to get a member from East. But just in the back of your minds while we're talking today and we talk about future goals, think about maybe folks who maybe we should be including and we haven't thought of that prior to this meeting. Next, we will go ahead. Dr. Remick is going to give us a background of the HRSA EMSC program. She is definitely the expert at that, so I will turn it back over to Dr. Remick.
Thanks, Lisa. I think, the goal here is just to help everybody better understand the EMS for Children program and the work that's done within this space. And Diane, feel free to chime in at any point as you'd like. I know many of you obviously know this very well, and I apologies for those that have heard this multiple times before, but I think it's important to make sure that everybody on the committee is really on the same page and understanding what HRSA EMSC is and what the EIIC does, so that you can better understand the footprint that the steering committee can have within this space and why it's so critical as we move forward and making sure that the care of injured children is improved upon. So the federal EMS for Children program was really born in the mid-1980s. And it sits under the HRSA Maternal and Child Health Bureau. And this is kind of an interesting location for it because the focus of EMS for Children, I think, is much more critically on the side of children than it is on the side of EMS. And so you'll notice that EMS for Children does not sit under NHTSA. And in fact, EMS is a bit, I would say, of a misnomer because oftentimes people see EMS and they think that the focus is strictly pre-hospital. But in fact, it's about the entire continuum of care from the pre-hospital setting to the ED, all the way through the inpatient care, rehab, and back around to injury prevention. And so it's that cycle that you see in the top right corner of really the different leverage points where we can impact the care of children. And the goal of this program is really the only federally funded program that's designed solely for the purposes of improving pediatric emergency care in the United States. There are other federal entities that may have a small slice of efforts or activities related to pediatric emergency care, but EMS for Children is dedicated solely to that effort. And the ultimate goal is to reduce childhood death and disability due to severe illness and/or injury. And doing so by really focusing on enhancing the current emergency care systems rather than creating a completely separate pediatric emergency care system, which of course makes a lot of sense. Within the federal space, the EMS for Children program benefits from a ton of partners that Diane is much more privy to speak to, but within MCHB, there are 11 total legislative authorities, and EMS for Children is able to work in partnership with many of those, in addition to entities like the Federal Office of Rural Health and the Assistant Secretary for Preparedness Response. But really all of our oversight is through the federal HRSA EMS for Children program. Diane, is there anything you wanted to add to that?
Nope, I think that's good.
Okay, perfect. So within HRSA MCHB, if you go to the next slide, Lisa, there are a few real key goals and priorities within the Maternal and Child Health Bureau. And that's not just for EMS for Children, but really for all of those legislative authorities that exist within MCHB. And so as a grantee or an investment within the Maternal and Child Health Bureau or under the Maternal Child Health Bureau, we really want to be attentive to the goals of MCHB globally. So they are about access, increasing access to care, and that certainly has been established through robust trauma systems, but how can we improve access for all children? Secondly, really fostering growing that healthcare workforce. And for those of you that are aware of pediatric readiness activities, we often think about this in terms of developing pediatric champions or pediatric emergency care coordinators, but there's certainly other ways that we might go about building that workforce. The third is really about diminishing disparities that exist, that we know exist in healthcare, both at, the level of, geography, states, territories, urban, rural, but also even more at the granular level in terms of race, gender, ethnicity, age. And I would say when it comes to EMS for children in particular, one of the largest disparities that we often focus on is the fact that children receive suboptimal care compared to that of adults. And so how can we really start to close the gap in that particular disparity? Partnerships are really core to everything that we do, which is why you see all these other familiar faces here. We really try to make sure that our efforts are not just, about sharing communication strategies, but truly partnering in a much deeper coordinated way. And then lastly, how can we create efficiency and effectiveness through program operations? And so that's something that we certainly hold dear. And I'll talk a little bit about some of the specific activities in those areas. But I wanted to just describe kind of the overall structure of the EIIC first before we kind of jump into some of those specifics. Sorry, if you could go ahead and click through the next slide. So there we go. So the HRSA EMS for Children program, so under HRSA MCHB, has 6 core investments within the federal program, of which the EMSC Innovation and Improvement Center is only one of those. So there are state partnership grants, which really form the foundation of the work that's done, where every single state and territory, currently 58, have an EMS for Children state partnership program manager. And the role of that EMSC state partnership manager is to work within their state emergency care system to ensure that the needs of children are included. Most of these EMSC state partnership programs sit within a state level office, for example, the Department of Health or the Department of Human Services, Public Health, EMS. However, there are some that are housed within academic institutions. So it's important to recognize that there is a little bit of diversity in these state partnership programs, but they all have the same goal, which is to really ensure that children receive equal or care that's on par to that of the adults within their state or territory. The EMS for Children Innovation Improvement Center, of course, is why we're all here in this particular group. And the goal of the EMSC Innovation Improvement Center is to work collaboratively with all of the other investments that you see listed here to ensure coordination, but also to really begin to push for more rapid transformation in emergency care systems through the use of quality improvement methodology. And so you'll see that integrated into all of our efforts, and I'll talk a little bit more about that. PCARN, I'm sure most of you are aware of. So there are 7 core nodes, each with associated affiliate nodes and an EMS node that really serve as the core infrastructure for developing the evidence base for pediatric emergency care. These are robust children's hospitals across the country and EMS agencies where they're really looking at how we can optimize clinical management in order to support best outcomes for children and use that evidence to push it more globally into the field. NEDARC, which is the National EMS for Children Data Analysis Resource Center, is really the arm for helping to gather data at a national level on behalf of the federal EMS for Children program. NEDARC has led the National Pediatric Readiness Project Assessment over the last 7 years and is getting ready to launch the next one here in the summer. NEDARC also leads regular national surveys and assessments of EMS systems to better understand the capabilities that currently exist for children. And they partner with all of the other entities and especially with EIIC and state partnerships to support those efforts. Sprout grants have been used to really reach into some of the more difficult to reach areas, the remote regions of our country, especially tribal and territorial regions where we know there's significant gaps and disparities in healthcare access. And then targeted issues grants are really innovation grants predominantly focused at the system level, as opposed to looking at patient level research that we see out of PCARN. The goal here is to develop strategies and innovation at that level so that we can push for improvements in systems and then hopefully disperse those throughout. So if you go to the next slide, Lisa, this kind of walks out those 6 investments and really where their focus lies, if you were to hone it down into just a few strategies, is that the EIIC is really focused on quality improvement efforts. State partnership is that foundational infrastructure with partners all across the US and territories. The NEADARC EMSC Data Center, which is really the accountability arm and is collecting data so that the federal program, HRSA EMSC, can report back to Congress on the impact of all of these various investments. The regionalization of care is about integration across more diverse systems and settings, targeted issues at innovation, and then last, PCARN is evidence generation. And really without all of these entities working in collaboration and in concert, we wouldn't be able to be nearly as effective in pushing the pediatric readiness needle forward. So when we think about EMS for children, it's really pediatric readiness across the entire continuum of care, pre-hospital, hospital, and so on around that whole cycle. So I'll stop for just a second before I jump into ARMS. Are there any questions about any of that before? I'm sure some of you have heard these terms. There's so many acronyms that I'm sure Mike and Erin and Lisa and Kathy Ali can attest to, that it becomes really challenging sometimes to be thinking about these. But if we use an acronym, yeah.
I like this slide that you put out, Kate, how you framed it and the roles of each of the acronyms. I think that actually was very helpful to me.
Oh, good. Perfect.
Yeah.
So if you move to the next slide, Lisa, when it comes to the federal program and really the goals of all of these entities together, is focused on these 9 core performance measures. And these are measures that essentially our federal partners are reporting back to Congress on. And it's the movement across these 9 performance measures that supports ongoing funding for the federal program. And as I mentioned, there's that criticality that EMS for children is truly the only single source of federal funding that's focused specifically on pediatric emergency care. So it's important for us to at least have these performance measures in mind as we're thinking about how we move into this next phase of promoting trauma care and decreasing morbidity and mortality for injured children. Currently, there is an evaluation team that's working on the next set of EMS for children performance measures. I'm not sure of the exact timeline of when those will come out, but it'll probably be another couple of years. Suffice it to say that these are really our areas of focus. So the top 3 are really focused on the pre-hospital realm. So the first is making sure that EMS agencies are participating in submitting NMSIS, at least NMSIS compliant data, because not every single state is compiling that NMSIS data, but submitting NMSIS compliant data so that we can truly begin to look at quality when it comes to the care of children in the pre-hospital setting, because without data, we can't do that. So that's the first. The second is that idea of building the workforce, but in the pre-hospital setting of having pediatric emergency care coordinators. I want to clarify that the intent of this is not the formality of that title as much as it is the intent of the role, which is to serve in a capacity where you are overseeing the coordination of pediatric emergency care at the agency level in terms of safety, protocols, clinical management, integration of evidence base and the like. And then the third in the pre-hospital realm is that we know children account for only about 7% of all EMS transports. And that because of that, most providers report seeing fewer than 3 children in a given month. And the frequency with which they encounter a critically ill or injured child and or perform critical skills is very low. And so the idea behind this is to ensure maintenance of skills through physical demonstration and skills practice. The next two, 4 and 5, are really focused on statewide recognition systems. So 5 is one that you probably understand more clearly, which is that we know there are, through ACSCOT and also at the state level, the designation of facilities, eventually verification and designation of facilities is level 1, 2, 3 trauma centers, looking at the verification of pediatric trauma centers and then subsequent designation of that. And that helps us to know which centers, which hospitals have the capabilities in place to manage trauma patients. But the counter to that is, how do we know which hospitals have the capabilities in place to manage pediatric medical emergencies? And that's where EMSC 4 comes in. And the goal here is akin to trauma, stroke, STEMI systems of care. Should we also be creating systems of care for recognizing facilities that are capable of handling pediatric medical emergencies? Looking at 6 and 7, this is really, we know that not all centers have all resources available to them, and making sure we have an ability to optimize interfacility transfers through the creation of guidelines, and then also agreements with comprehensive centers. And then the last two performance measures, 8 and 9, are really focused on formalizing the EMSC program within every state and territory. First, by creating a space for a voice within the emergency care system. So whether that's through trauma councils at the state level, or ensuring that there's, pediatric advisory councils, a pediatric voice, that's really what 8 speaks to. And 9 is really taking it even a step further to integrating all of the priorities that I just mentioned into state and territory statutes and regulations that will impact, for example, hospital licensing, EMS agency licensing, and things like that. So it's a lot, but I think it's important to keep these in mind. And so what you'll see is that the focus clearly for EMSC is really at the system level. It's not quite as granular as some of the other efforts, but really beginning to push towards this kind of shift in data collection and optimization of systems of care. If you go to the next slide, Lisa, I'm sorry, I'll try to go quickly. But within EIIC, our mission is really to accelerate improvements in quality of care by using quality improvement methodology. We know if we wait on passive uptake of evidence base, it takes 10 to 20 years before some of these more community rural institutions will really begin to integrate that knowledge into practice. And so what we really try to do in the EIIC is to use quality improvement methodology to provide practical resources and guidance to truly integrate that evidence directly into care. And so that's our primary mission, our goal. If you go to the next slide, though, thanks. We know that within every organization, there's vision, mission, values, goals, and so on and so forth. And so I just wanted to share the vision statement for the EIIC that we currently have in place. And that is that one day, every child and family will receive the highest quality emergency medical care through EMSC optimized systems. So that's our ultimate vision. And there are a few core values that we lean on. So as I mentioned, improvement, science, and collaboration, but also enhancing our communication strategies. The other is making sure that we can be nimble and responsive to changes in both federal needs, but also gaps that we begin to see as things like pandemics present themselves. Really looking at that system level, so system-based solutions. Equity is one of our highest values and importance areas. And then of course, partnerships and some support of that larger EMSC community. So those other 5 investments. And the strategies that the EIIC typically uses is, listed here. So definitely partnerships, key and critical. But then development of educational resources and tools that can be used in our quality improvement collaboratives, really beginning to build on more robust analytics to really demonstrate those improvements over time, enhancing our marketing so that it's clear that all 6 of these investments, and even within the EIIC, that we're all part of one, singular mission and vision. And then through advocacy with families and other partners to better support this work. Go to the next slide, Lisa. So within the EIIC, we have 6 core smartings, and those are listed here. And these seem probably, you know, a little intense, maybe to say the least. I mean, these are big goals, and if you haven't been in this space long, it may seem daunting to be able to get here, but it's because of all of our collaborations that we've been able to be successful. So I'm going to read through these because, again, similar to those performance measures, I think it's important to know what they are. So our first goal is that, you know, by the end of this grant cycle, is that we are trying to ensure that at least 15% of the nation's EMS professionals have accessed a central repository of evidence-based resources. The second is that for those individuals who participate in our quality improvement collaboratives, that's what QIC is, that we see an increase to 50% of agencies and hospital facilities that report true improvements in the quality of pediatric emergency care. The third is that we are underway with efforts to ensure that at least 1,000 pre-hospital and hospital pediatric emergency care coordinators receive information on effective methods to improve the quality of emergency care delivery. Our other goal that's in complement to that is to ensure that those same, or at least another 1,000 pre-hospital and hospital professionals report improved knowledge of best practices through continuing education and the like. To ensure that 80% of EMSC recipients and stakeholders have access to high quality resources and guidance that help accelerate improvements. And then the last is really a focus on telehealth. And I know, Dwayne, you're very aware of this, but that we've just recently launched a telehealth collaborative to try to expand telehealth programs, as this has really grown exponentially over the last 10 months since you know, the pandemic hit, and we've had to begin to think about other ways to improve access to pediatric emergency care. So we're currently working with 7 states that are developing very diverse programs to promote telehealth use and uptake. Any questions about those?
Can I interrupt you just for a sec, Kate? Can you
Yeah.
go back a slide, Lisa? So Kate really undersells the reach and influence of the EIIC. I mean, you're so humble when you speak, and 1,000 PECs, right? I mean, the reach that the EIIC has is astronomical. I mean, these are, look, nobody writes a grant with aims that they're not going to achieve because they want to get funded for the next round, right? These are easily achieved, well, not easily, but these are achievable goals. And I mean, how many PECs are already part of the PRQC collaborative? It's like 500 already, isn't it?
Yeah, so with the Peds Ready Quality Collaborative, that involved about 130 hospitals across 17 states. And at each of those sites, we had multiple individuals or multiple champions.
Yeah.
Yeah, it's to the tune of about 400 plus. Yeah.
So I think that the infrastructure that's been built and the access that we have to a lot of these hospitals that participate in these quality improvement collaboratives is just an amazing network that we can push educational content out over. And you know, as everybody on the committee will see in the coming months, you know, the infrastructure with which we can push these things out it's amazing. So I appreciate how humble you are, Kate, but this is really a great opportunity for us to reach, you know, 1,000 PECs at many small community hospitals that are just dying for pediatric content because they know they can't take care of kids. They know they're not ready, and they're reaching out to the EIIC to try to improve care. So we already have an engaged community of PECs and pediatric emergency care coordinators that are just looking to us to provide them something to implement. So we have a ready and willing audience that wants to collaborate with us. And this is really powerful. So don't undersell it. Keep going.
Well, you know, it is interesting, you know, so we usually take our quality improvement collaboratives and we push them into a community practice after that more structured phase. And today we had our pediatric medical recognition program community practice. which, you know, I spoke to. That's Emsc Performance Measure 4 of trying to develop a statewide program. And we currently, whether you know it or not, there are currently 17 states that have recognized one or more facilities as part of a pediatric recognition program. And Lisa led this community of practice earlier today, but it was very interesting because a gentleman by the name of Brandon Kelly, who's the Wisconsin Wyoming, another W, EMSC state partnership manager, spoke to exactly what you're speaking about, Erin, is about this ability to really be there for the communities. And I think being a physician in some of these rural or under-resourced areas, it never feels good to have a critically ill child or injured child come in that you just can't handle. And so I do think there's a growing momentum to really affect change, which is exciting. Thanks, Erin. So if you go to the next slide. So how do we do this within the EIIC? This is a little bit of a complicated slide, and I don't want it to be overwhelming because these are somewhat false constructs because we really do work collaboratively within the EIIC space. But in order to achieve the goals, we needed to make sure that there was a team focused on the various areas of pediatric emergency care. And so have really tried to create this matrixed model where the blue columns, where you see disaster, trauma, pre-hospital, hospital, state partnerships, research, these are really some core content areas of focus. And the gray rows on the left are really mechanisms, strategies, if you will, to try to achieve various goals and efforts or to foster those efforts. And so it's really collaborative. And even though we have those separate, blue columns, there's really, these are very much blended and that each of these teams work together. But Mike and Lisa and Erin are really the leads for this blue column entitled trauma. And so that's really where that sits within the EIIC space. And similarly, we have an amazing team, I would say, of about 50 individuals across the entire EIIC. I mean, it requires a large and robust team to be able to achieve some of these goals and these individuals across that space. And as Mary alluded to, she is a member of the EIIC Advisory Board, which you can see there on the top left, where it says Advisory Board, which really helps to provide so much guidance to us overall, but really a large team. And in addition to ASAP, ENA, and ACS, we also partner formally with the National Association of State EMS Officials and also the American Academy of Pediatrics. So recognizing that as some core partners and being able to disseminate and support efforts across the country. And then the last piece I want to point out is the CCIT, is the Center for Collaborative and Interactive Technologies. They're based at Baylor College of Medicine. And they are really an incredibly innovative technology arm for the EIIC, and that they build and have developed our entire website and platform as we continue to make updates and adjustments to that. And they've provided some really fantastic ways for us to be able to begin to get at analytics within our website. And as you all begin to think about what the priorities are within this particular domain of trauma, recognizing these various resources exist within the EIIC is important. So, and then I think I just have one more slide, Lisa, which is just to go back to those HRSA MCHB goals and really walking out, the crosswalk of how we're addressing these various goals. So access is really using quality improvement methodology to help really disseminate tools and resources across the entire emergency care space so that that knowledge begins to grow and build across the nation. The other is, on healthcare workforce, we are getting ready to launch here in about 6 months or so, a PEC workforce development collaborative, where we're really trying to engage healthcare providers on the front lines to help them to become those champions. And by providing the tools to be able to do that. So we have a series of toolkits and also these relatively new PEAKs, which are pediatric education advocacy kits focused on specific clinical conditions. In terms of equity, there are certain areas of focus that we really are attentive to, certainly our tribal and rural areas, but we also think about equity in terms of children with special healthcare needs and access issues and certainly behavioral health, which is now of epidemic proportions, but really trying to integrate that throughout our work. Partnerships, as I've mentioned, and we really have a robust family advisory network, and I hope I know you all have identified someone from the FAN to be part of this steering committee, and I guess they haven't joined yet, but I think that's really important that we keep families' voices front and center to the work that we do, because that's really what makes it so critical and so meaningful, alongside our state partnership managers and state chapters of national organizations, as well as at the national level. And then in terms of, strengthening our program operations, we now have a full analytics arm within the EIIC, which has really been, a big push during this grant cycle. And then I think that real integration of efforts in terms of shared priorities and shared activities, even with our national and partners and federal entities, has really helped to strengthen our effectiveness. So hopefully that gives a big overview. I'm sorry I took so long. I did not mean to take so long.
Take a big deep breath. No, you're good.
No, that's great. Thank you.
We're still on schedule. Don't worry about it.
Okay. To end early, right?
Yeah.
Dr.
Like I said, Kate, I always appreciate when I hear you talk, because I learn more and more about the space and the EIIC each time. So I appreciate it.
It is very complicated. I mean, I think, there's this expectation sometimes that we push this out and everyone just gets it, but it takes a lot of time to really learn it. So I'm glad to hear that.
And
I've seen those slides 5 or 6
Thank you.
times, and I learn something new every time.
Right.
It's so big that it takes a while to learn it, but it's so big. It's a great thing to be a part of, and it's a great opportunity. So cool. Any questions for Kate about EIIC and where we sort of fit in?
I just did want to make a comment, Dr. Jensen, just for awareness, and you suggested I do this and I forgot. For committee members, we do have 2 Family Advisory Network members who weren't able to be on the call today. One is actually a nurse by background. So we have 2 FAN reps. We have a representative from Society of Trauma Nurses who wasn't able to be on today. So, and then Dr. Maxon, we talked a little bit about before we started our call. He was a little confused on dates and times, but we will bring all of these people up to speed. Not only will I post that recording, but we'll send them the recording, and they will be actively involved moving forward. They just weren't able to make the call today, it looks like. So I failed to recognize them earlier. So, okay, moving on. Thank you.
We've also asked, our ask for EAST, the Eastern Association for the Surgery of Trauma, was actually for an adult trauma surgeon. So we're going to have input, because many kids are treated at adult trauma centers without pediatric expertise. So we've specifically asked them to provide us somebody to provide input from the viewpoint of the adult trauma surgeon, so that we can make sure that we're meeting their needs as well. So as we go along with our discussions, if anybody has any thoughts about other stakeholders that we have overlooked that should be part of this group, please let us know, because we want to engage viewpoints of everybody who might be involved in the care of kids. So we've gone over it over and over and over again, but we're pretty sure we've missed 2 or 3 people that we should have invited. So feel free to point out who those people are. Cool. Mike, I think you're up next.
Yeah. My part was just to take a few minutes really to talk about really the goals and purpose of the steering committee. What are we all doing here? We've alluded to it already with part of what Lisa and Erin and Kate have been talking about. But the first priority in this redevelopment of the trauma domain under the EIIC version 2.0 was really to establish a steering committee. And we wanted it truly as the Patel said, the steering committee, meaning a group of individuals from a variety of kind of different backgrounds and experiences to help guide us in developing our priorities for this space. So again, we appreciate all of you taking the time. We know everyone is pressed on time. We appreciate your efforts. We do view this, as Erin and Lisa were saying, as a malleable thing, meaning this how we decide it's set today doesn't mean how it's going to be set from 6 months from now with the structure of the steering committee. We want your experience in pursuing groups like this to help guide us also. So feel free anytime to reach out to us to say, hey, we need to be meeting less frequently, more frequently. This is our recommendations for how we should be structuring it. We're always looking to your expertise and guidance. So, what are our goals here? It's that just like Kate was saying with the EMSC and looking at the continuity for emergency medical services for children, not just in the pre-hospital, a lot of people think of it, but really across the board, how can we impact that? As Erin said earlier, we're, as a level 1 pediatric trauma center or level 2 pediatric trauma center, you kind of know what you're doing, right? You know how to stabilize a kid. Even the high-level adult trauma centers often know how to stabilize a kid. I don't think we're looking to necessarily impact that space. What we're looking for really is to help the more underserved hospitals in oftentimes rural spaces, what we consider critical access hospitals or potential level 4, trauma centers. How can we help guide them in pediatric trauma care? How can we help them take care of an injured child, a severely bleeding child, a critically injured child? How we decided to kind of set up this is right now quarterly meetings, with the first one today really just being this introduction. Erin's going to go a little more into the quality improvement projects, but what we're going to have followed out is a survey that's going to follow this meeting with a list of questions about what your thoughts are in kids in the trauma space and how we can impact it. What should our target areas be? And then we can start to develop strategies around those target areas.
Mike, this is
our next
Terry.
meeting. Yeah.
I have a question. Something popped into my mind when you were talking.
Certainly.
You're talking about, working with level 4 trauma centers where pediatric trauma is very low volume for them. Would you envision working with regional pediatric trauma centers? Because I also see that, of course, as my role in helping my referral sites, with that pediatric education with trauma and things like that. Do you see there could be some collaboration there? Because I just don't want people reinventing the wheel because I'm doing that, but I think a partnership would be the ultimate.
Absolutely. Even providing some sort of guidance to those places, toolkits for those places. Exactly right, Terry. Because at our trauma center, we do the same thing, right? We have a wide variety of critical access hospitals we're serving that send us, just a couple of kids a year that we're always trying to feedback and educate them. And we're always looking for ways that we can do that better.
Okay. Sorry to interrupt.
No, you're fine. So the next, just so awareness, we'll email this out to the next meeting on the calendar is for April 28th. We'll have email communications, obviously before then. We view a lot of the work probably can be done by email and smaller group meetings in between these quarterly meetings of the steering committee. Anything else, Lisa and Erin, I'm forgetting to discuss about the structure or the goals of the committee?
I don't think so. I think we've been tasked to identify 3 national trauma priorities, and then the 4th thing is sort of to work with trauma systems to figure out perhaps how to better. I don't want to lead people down a road, but really look at trauma systems. And very few states actually designate level 3 and level 4 trauma centers for kids. Most states are level 1 or level 1 and 2. And I think the 4th goal for us, independent of the 3 things that we come up with, is really working with the ACS Committee on Trauma and state partnerships and try to figure out if we can come to some consistency about, how can we identify some of these critical access hospitals that may or may not be level 3 and level 4 adult trauma centers, and how can we ensure some degree of consistency and quality of care for kids within those centers. And that might even lead to verification for level 3 and level 4 pediatric trauma centers through the American College of Surgeons. Obviously, that's a multi-year project, but we have 4 years to do this. And I think that particular goal, which is sort of the add-on goal for year 4, the way the grant is written, is something that will continue to sort of infiltrate all of our discussions and conversations about how do we ensure quality of care in many of these places, and how can we bring some sort of uniform structure to the system without being too restrictive or onerous on these centers, because they're all very resource constrained. So yeah, and I think the collaboratives, it's really important to understand these collaboratives as effector arms of what we do. This is how we can push out our work. It's how we can push out the educational content and protocols that we think are important. And we really have access to a lot of people who are really interested in improving care. And I think that the first thing that Kate talked about is one of the number one goals for EMSC is to improve access to quality of care. There's 2 ways to do that. I can take every kid in California and have them all move within a block radius of my pediatric trauma center, and now they all have access to high quality trauma care. Or we can push high quality care out to these rural and community hospitals such that people have access to quality of care. We can't move everybody closer to the pediatric trauma centers, but I think we can move our standards and our protocols and a lot of our practice patterns out to them, and we can influence best practices, and we really can improve care locally within the trauma system. So that's kind of the focus of what we're working on. We just have to decide what are those priorities going to be, and then get to work on sort of pushing out the educational content and protocols and feedback mechanisms. And as Terry said, working with regional pediatric trauma centers to serve as resources. I think this is all within the scope of what the steering committee is tasked to work on. So any questions for us about sort of what we've been tasked to do?
I know some of it still sounds a little vague. That's because it is, because part of the first part of the steering committee really is helping develop the priorities.
And I think to be very, very succinct and objective about what we are tasked to do, we are in year 1 right now of this EIIC grant, and it's a year 1 of 4. In year 1, our task is to identify what the priorities are. So we have until June to really identify the top 3 priorities, the things that we want to fix from a quality standpoint within pediatric trauma systems. And then each year, the following years, we will work on one of those priorities. So whatever, say we choose as a goal to decrease overimaging of kids in rural and community access hospitals. Next year, we will work on figuring out how to address that problem. And then, the 2 other problems that we identify, we will work on in year 2 and year 3, and so forth and so on. So the work of this committee for the next 5 to 6 months is really identifying what are the key things that we would like to tackle to improve quality of care locally for kids that are maybe not treated at pediatric trauma centers. Does that make sense? And this is really a low-hanging fruit project. I mean, I don't know if Kate, you want to speak to this, but one of the things that the Peds Readiness Collaborative was working on was just making sure that every kid gets a weight in kilograms to impact medication dosing. Like that seems like such a simple thing, but it's so impactful. If you can just get everybody to weigh kids in kilograms and to recognize abnormal vital signs, you've won half the battle. I mean, to us who take care of kids all the time, that seems like such simple, and like, why do we even have to think about that? But if you're somebody who doesn't take care of a kid very often, those are really important things. So, the low-hanging fruit, the things that we can push out, and we're not here to generate evidence. That's what the PCARN group is for. We're here to take best practices, and we're here to take the best available evidence and push it out to the community to make sure that kids are getting the highest quality care. So, we're not going to push out a project to figure out how to better manage, coagulopathy that might be better than TAG or something like that. We're here to take the PCARN head injury rules and make sure that everybody has read them. I gave a lecture to a major adult trauma center, to their trauma fellows. And these trauma fellows are now 2/3 through their fellowship. And they were asking me about head CTs in kids, and they'd never even heard about the PCARN rules. And it's like, but really? Like, everybody I know, this isn't standard of care in pediatric trauma centers. How could you not even know about these? And they were amazed. They're like, wow, there's a 0.01% chance of a clinically important brain injury. Why would I ever scan that kid? But every kid who comes through my ER and scanning. And those rules have been out since 2006. We're 14 years in, and you know, at a major urban academic adult trauma center, they're not teaching their trauma fellows about those. So I think the whole 17-year rule for evidence to get out is actually real. So, you know, if we can identify some things that we need to push out there, we have a huge ally in all of these networks and quality improvement collaboratives to get the information out. So questions about our task and our goals and our mission and so forth?
Dr. Jensen, just a quick question from Diane Pilkey in the chat box. Is pre-hospital EMS represented here? So I think that that's a very good point. In our small little domain group, we had discussions about the best way to recruit, if you will, someone to join us, whether it's going to large NSIMSO organization. So the short answer to your question is no, we don't have a boots on the ground EMS provider on our committee. And any ideas or suggestions about how to get the right person to fulfill that role would be welcome.
Mm-hmm. Yeah, I think that's very important. And we had discussed it, and I think sort of fell apart when we didn't know who to go to for a representative, but we could even engage the pre-hospital domain and see if there's anybody that they can push over to us, or Diane, if you have any suggestions, we certainly would be open to that. But I think their voice is certainly very important.
Absolutely.
And yeah, Dwayne, I see that, because I was listening to Dwayne introduce himself, and I was sort of thinking we don't have any pre-hospital, but he seems to have a lot of that experience. So I think we have a little bit of a voice there, but if we want to formalize that, I think it would be very helpful.
Yeah. Dwayne, do you think we should add another person in, or I mean, with Dwayne on, I think that's probably a pretty good representative.
I wouldn't be against it. I think it's good to have, you know, always a second opinion. And yeah, I've got a few years into it, but I'm coming from a geographical area, and I think geography really makes a difference in a lot of considerations. So having someone from a different area, maybe a remote provider, and the challenges that are there versus I'm an urban suburban guy. Yeah.
Okay.
Cool. Yeah, we can try to identify somebody in the coming weeks, probably pretty quickly, hopefully. Mm-hmm. To get them rolled in. Okay, cool. Should we move along to the next
topic,
Lisa? So I just wanted to take 10 minutes or so to let people sort of brainstorm out loud about some ideas that we might want to discuss as topics or tackle as some of those priorities. Today's discussion is not going to be extensive, but it's going to just sort of frame people as to what sorts of things to talk about. The way that we're going to document all these things is, as Mike mentioned, we're going to send out a survey, a free response survey, to ask you guys to put in your ideas. And then we're going to do 2, maybe 3 rounds of Delphi review, where we will send you guys all of the topics that you all gave us and ask you guys to vote on what those priorities should be. And then after the first round will be our April meeting. So we'll sort of discuss them and then we'll vote again. But some of the things that we wanted to put out as sort of framing questions, and these are the things to sort of think about. So, you know, if you were to say, what are some priorities? What should we be working on to improve quality for injured kids? Think about non-pediatric adult trauma centers. So for me, there's a very high functioning adult trauma center 1.3 miles up the street. They're not good at taking care of kids, and they'll tell you that. And the reason is because we're 1.3 miles away from them, and EMS brings us all the kids, but every once in a while, a private car will bring a very small kid who's injured to the county trauma center. So thinking about that center, what do I think we could provide them as resources to improve care for kids there? Think about those rural and critical access hospitals where maybe there's one family practice provider who's manning that ER on the weekend. Think about the large community hospitals that may be in your urban metropolitan center that's not a trauma center that may take care of an injured kid. Think about trauma systems or pre-hospital EMS systems. What potentially could we do to improve care in those systems? And this gets sort of back to what Terry mentioned earlier. What are the outreach needs that perhaps we as pediatric trauma centers or other centers have? How can we better equip centers to collaborate to improve care? What are some resources we can give to centers to push out? And really think about dissemination and implementation science. We really want to take best practices. We want to take evidence-based practices and the things that all of us may be doing in our centers and pushing them out. I think about a kid who I received at our trauma center last year who, had an emergency splenectomy, and he got massively transfused with 4 adult units of blood in a 15-kilo kid, and he got no FFP and no platelets. And I asked myself, why did they not give him products? Well, they sent us their massive transfusion protocol for adults, which after 4 units of blood, it kicks in with FFP and platelets at 1-to-1-to-1 ratios. But what they didn't realize, they'd already given this kid 2 blood volumes worth of red cells, and he's coagulopathic. So, I take that case and I say, well, maybe a pediatric massive transfusion protocol for critical access hospitals is something that could be very valuable, because that's something that they're going to see every 3 to 4 years. But when they need it, they need quick access to it, and they need to know where to go to find it. We talked about imaging. We talked about some of these other things. So, as I discuss these things, does anybody have any thoughts that pop into their mind off the top of your head about topics? And this is brainstorming. There's no wrong answers. Mary, you got your hand up. You can go first.
So I think that there are multiple layers of complexity to this. In the rural areas, people are petrified of kids.
Yep.
And they are not really communal with us because we criticize.
Right.
So they send us a patient who doesn't look well. We don't provide feedback. And if we provide feedback, it's usually not in a positive way.
Right.
What we need are networks of care, transfer policy and agreements that EMSC has been promulgating for years and years, that would enable somebody to pick up the phone and say, Jensen, I need help, this patient here in my emergency department. This is what they look like. What do I need to do? And how can I get him to you best? And we have not made people comfortable doing that. And I think this is a great collaboration. I've been in ESC for years because of an opportunity that became a way for me ultimately to be the program director for Emsc and done for years and years. And so I know about EMS at the rural and critical access hospital level. And when you have hospitals and providers who don't see kids very often, what you have to do is make them want to get the attention. You have to be nice to them. You have to promulgate a relationship and cultivate it so that they want to listen and want to experience this. But you can't shove it down their throats, because then they will become will reject it. Basically, they don't want to hear it unless they're engaged. And so what this is about is engagement. And what EMSC has been able to do in all these states is to very slowly but steadily get engagement from local level, so that they want the information and they're involved, and to make sure that people know that this is not an extra FTE. This is part of the program. This is part of taking care of every patient that you're going to pick up and do a run on, and part of them are kids. Maybe it's only 5%, 7%, but they're still important. And when you take care of that kid, you really want to do the best thing you can. But it's a marathon, not a sprint. And I think our role ultimately is to engage our own people, help them understand that this is important, that kids are important, increase awareness of pediatric readiness, engage people in level 3 trauma centers who take care of kids and give them more information so they can do it better, provide essential feedback they need both to EMS and to the surgeons who are taking care of the patients. There's lots of ways to do that, but it's a two-way street, right? we have to be nice. We have to provide innuendo and then follow through on that. But they have to be receptive and feel that we're being helpful, and then they will want to take care of better care of the kids and not just ship them. But I think these networks of care with transfer protocols, agreements, and ways to connect with people that they feel that they can reach to us for advice immediately if that's what's needed, with medical direction, would be the most helpful thing that we could do, is to build that kind of network. And I think Eileen Alter in the role of the COT chair is our best way forward. She is very interested in having level 3 pediatric trauma centers. She recognized the void we have in this country in spaces where there aren't any pediatric level 2s or level 1s, but there's lots of 3 trauma centers. And that's the target audience for us, is to try to elevate status of children's care so that kids can stay at home and they don't have to get shipped miles and miles, but also that they get better care at home are getting now. Yeah. Sorry, I'll get off my soapbox.
No, it's 100% correct. And the whole judgmental feedback thing is a real problem. I do think this is one of the main benefits of the EIIC and the collaboratives that are out there, the quality improvement collaboratives, where it's not really feedback coming from the Ivory Tower Trauma Center. This is a grassroots effort where educational materials and other quality improvement materials are being provided to hospitals that really are petrified of kids, as you say. So it does give us an opportunity to give not case-directed feedback, but materials in response to recognized needs in a non-threatening manner. So I really like the networks of care and the nodes thing. I think we certainly should investigate that further. Other thoughts, other things that people are thinking about as we're get our collective juices going on the call?
I'd just like to ask a quick question. When we consider some of these more rural hospitals, as well as those partners that we're collaborating with, do we have access already to needs assessment or problem identification that has come about already from some of these larger other additional larger organizations from which we can kind of lean on to help guide our decision making?
I'm not aware of anything that we have. Kate may have some thoughts on that, but that's something that we can do if that's something that.
Does anybody know how long it's been since all of the hospitals in my state at least filled out a pediatric readiness survey, but that's been a while ago. I mean, at least, well, I'm a horrible judge of time, but
2013.
Okay, well, I guess it's not that long, but it's a long time. So that might be a source of some baseline data at least.
Yeah, I mean, I think it depends on what data you're looking for. I mean, the NPRP assessment is coming out again in 2021 this year. It'll launch on May 1st for a national reassessment. I think, you know, some of the concerns we have is just the current state of emergency care in this country with COVID, but we hope that there'll continue to be a high level of participation. But in terms of access to other assessments or data sets, I mean, there is some work that's being done in this area, but that has not historically been the predominant work of the EIIC. You know, I mean, I think much of the work has been to create opportunities for engagement, like Mary was talking about, as opposed to pushing out big publications on the current state, but instead using that information. Now, there are individuals that are in PCARN or Target Issues grants that are working with some pretty decent data sets, and there may be opportunities there, but I don't know that that's historically been where the resources lie within the EIIC.
Yeah, I think, you know, I'm not aware of any access that we have to any needs assessment for what hospitals need as far as pediatric trauma resources, but I was sort of hoping that our representation from the Family and Advisory Network might provide some insight into that, perhaps some of our state partnership chairs. We might be able to get some feedback, and they can even go back to their organizations and representative groups to ask. We also have a research fellow who's unable to be on the call today, Caroline, who, if we want to do a needs assessment survey, we can do that. I mean, we can get a list of hospitals and send it out, and she could spearhead that, and we can do that. I think that would take a year to probably get the results back, but certainly as we move forward, that might not be such a bad thing to do. Other thoughts, ideas that people have?
I did a rural surgeon survey to look at what types of surgery on children really rural surgeons perform, and what their resources are and what the gaps are. And it's published in the Bulletin of the American College of Surgeons, like in December of last year, and it has 2 tables in it. One is a table of CME type education that they would value, but the second is what they lack, and that is something that my pediatric colleagues might be able to help with, because they said they lacked pediatrician support to take care of the kids, including helping them and take care of them in the hospital. They lacked infrastructure within the hospital to provide the support they needed to take care of a population that was maybe only 5% of their admissions. So it wasn't a priority on the part of administration. And some cases, I think the people who've been taking care of kids for a long time are going to retire, and they have no plan for who's going to feed them, who's going to put the kids to sleep. So we need collaboration from anesthesia. We need collaboration from our colleagues in other surgical subspecialties. But we also need infrastructure at the hospitals, and we need pediatrician support. And so those are 2 things just to think about if you're going to target critical access hospitals, because many of the pediatricians don't go to the hospital anymore. And so you've got somebody from family practice or internal medicine is the emergency department physician seeing these patients, screening them. So there are, I gave a talk at the Northern Plains Rural Surgical Society a couple of years ago, and I talked about pediatric trauma and pediatric readiness, and their eyes glazed over. No one knew what I was talking about.
Right.
And so these are, these places where they're trying to survive, some of these hospitals.
Exactly.
So this is not a priority. In order to make it a priority, first of all, we have to raise awareness, I think, of the concepts that we're trying to bring to them.
Exactly.
This is Terry. Just adding on to what Dr. Pallett said, it makes me wonder if there isn't 2 different goals that we should think about. So, like in my region, I'm surrounded by level 4 hospitals. They have no pediatricians. They have no pediatric trained nurses. I actually don't want them admitting pediatric patients.
Right.
So I think that we might have that goal for some of the larger centers, perhaps. But for me, I think I would rather, make a secondary or, co-running goal of what information can I provide to that family practice ED physician to get him to recognize the shock, treat it appropriately, and get that kid out of there as quick as possible.
Yeah.
I don't want them admitting that kid, because that's
I think that's the low-hanging fruit, and we've had a lot of discussions about that too. How can we ensure that rural and critical access and community non-trauma center hospitals can adequately stabilize and resuscitate a kid, recognize shock, recognize that there's a real problem, all without over-imaging. If we can meet those 5 goals and get kids, in and out of those hospitals with appropriate resuscitation without over-imaging, I mean, that's like the win of the century right there. It
100%
seems simple,
agree.
but it's probably not that simple. All right, I promised we'd finish early. So Lisa, let's go to the next slide so we can wrap things up and get people on their way. Yeah, this is the survey, one more. So you're gonna get a survey from Bhavin, who is gonna keep track of all this information for us. And this is an outline for the next 6 months of what we're planning to do. The January meeting is today. April meeting is halfway, and then by July, we hope to have our priorities identified. So the arrows are shifted a little bit on this screen, but you guys later this week are going to receive a survey from Bhavin. We would ask that you fill it out within the next 2 weeks. It's a free text response survey. It's just fill in your thoughts. It's brainstorming. It's spill your brains on the screen so that we can just get ideas from everybody. No idea is a bad idea. More information is better. Whatever you think might be helpful, just put it in there. After we get your responses, we will collate them. We will review them, and if a couple of you guys gave the same response, we'll sort of mix them into the same answer. And we will put these into a survey. And I don't know if anybody's ever done Delphi review before, but we will take all of the items identified and we will ask people to rank them for priorities. And if there's 40 topics, we'll have you rank them. And after they're ranked, we sort of maybe cut off the bottom 20 and we then send it out again for re-ranking of the top 20 because people would then change their mind when some of the options go away. And hopefully by the end of 2 or 3 rounds, we will come to consensus on the top 3 topics. And maybe there's 5 or 6. So we're hoping to have at least the first round done before our April meeting so that we can sort of discuss the merits of some of these priorities. And then, at the July meeting, if we still haven't come to consensus, I think we can have another discussion. But hopefully by July 1, we have our 3 priorities identified so that at our July meeting, we can really start to talk about how we're going to tackle these problems and implement solutions. So this is how it's going to be a lot of email and survey work. I hope it won't be too onerous and time consuming. I think each of these surveys you'll be able to fill out in about 10 minutes. And there'll be a lot of discussion, but we really want input from everybody. I think during the introductions, everybody realized that we have a lot of diversity of backgrounds on this call. And we're really hoping that we get different answers from absolutely everybody, because I'm pretty sure that Dwayne's going to come up with 6 things that I've never even thought about. And see what he comes up with. I'm going to say, yeah, those are the things that we need to work on. So try to think outside the box, give everybody else different ideas to think about. I had never thought about tackling something like Mary talked about with nodes and providing feedback in a safe environment. And that's a brilliant idea. And maybe that's what we decide to do. But you guys are all asked to help us because you're really smart and you have really good ideas. I'm the dumb one on the call. I'm just supposed to sort of herd the ideas and organize everything. So we're really relying on you guys to really give us some ideas. So we look forward to hearing back from your survey stuff and seeing you guys in April. I don't think we've identified an April meeting date yet, but perhaps Lisa, have we identified that date?
Yes, we have.
We put it tentatively on the 28th.
Yeah, why don't we just have everybody sort of respond to availability on that date? And if it seems like a lot of people aren't available, we may need to do a doodle and pick a different date and time. But
Okay.
Hopefully, since it's 3 months out, we should be able to make our schedules available, I would hope. Cool. We're 2 minutes ahead of schedule. Any last minute thoughts, concerns, questions? We will never go over. I promise our meetings will never go over. I can't stand meetings regularly. Cool. All right.
Thanks again, everybody. We do appreciate your time.
All right. Have a good evening,
Thanks.
afternoon.
Bye.
Thank you, everyone.
Thank you all.
Thank you.